psychosocial, pharmacological, combined and sequenced interventions for ADHD, and I do think that we too quickly jump to medication in children, and we shouldn't. And I'll give you a couple of reasons why I think that's the case, and then I'll show you the latest study that we've done that was published last month. That's the first study of sequencing treatments for kids with ADHD, whether it makes a difference if you start with medication or if you start with behavioral intervention. And we were quite surprised at some of the results. I think you'll find them interesting. So let's move ahead. Disclosures, I haven't worked with pharmaceutical companies in quite a while, but I've done a lot of work with them. Our lab published the first study on Concerta, 2 of the first 4 studies on Adderall. We're part of the Adderall XR clinical trial. So we've done lots of work with pharmaceutical companies in the past, always, from our perspective, looking at the incremental value of medication on top of behavioral interventions. And I was the principal investigator in the MTA study, which many of you may have read. Actually, how many people have read the MTA study? How many people have not read that? Let me just see. Oh, that's interesting. So way more people have not heard of the MTA than have. So I don't have to educate as many people here, so I'll skip that. Here are a bunch of the people that we worked with over the years. Gene Hirschman, who's not here today, worked with us on a project for the last couple of years. We have lots of collaborations across the country, which is the tradition now in science. No person can do stuff alone. Those 15 grants that I'm on now are not 15 grants where I'm the sole PI. They're mostly collaborations with lots of people. Here's 3 ADHD boys at a picnic. French fries, not clothespins in their noses. And then this is an ADHD girl at the same picnic. You can see it's a different choice of edibles, but she's still got something in her mouth. Prevalence of ADHD. I showed this slide now. When I first started showing this slide a long time ago now, back in the early 1980s, it said 2 to 5% is the prevalence rate, because for years that was what people thought the prevalence rate was. And then as people began to do more national surveys and his definition of ADHD got tighter and it got more awareness, then the prevalence rate went way up. 9 to 12% is what the CDC came out with 3 or 4 years ago, saying that was the prevalence across the country with some variability. It's the most common behavioral referral to healthcare professionals, most common diagnosis that kids receive in special education, and it was even before ADHD kids were eligible for special ed. The most common cause of behavior problems in regular ed classrooms, and the most common diagnosis in child mental health clinics. So it's a big public health problem. How many people have read this book besides me? I hope, I'm not going to ask the next question, which is, do you have children? Because I don't want to embarrass you if you read the book and you don't have kids. But these are delightful books, and I learned about this because my son was reading it, and he came downstairs when he was reading this version of it, and he saw this paragraph in that book, and he said, "Hey Dad, isn't ADHD, aren't those the kids that you have in your summer camp every summer?" So I didn't know that George and Harold, the 2 people in, or the heroes of the book, George and Harold had ADHD. And they started to leave, and he came back and said, "You know, there are kids in my class that behave like George and Harold. I wonder if they have ADHD also." So I learned about this from my son, and that just goes to show that kids know that kids misbehave in classrooms. They've heard the term ADHD before and so forth. So, you know, if you've not read this book, so I'll just tell you that it's about these 2 boys who were the troublemakers in their school. And in an earlier book in the series, George and Harold bought a magic ring over the internet that hypnotized people, allegedly. And they used it to hypnotize their principal, the mean old Mr. Krupp. And they gave him a post-hypnotic suggestion that when they snapped their fingers, he would take his clothes off, down to his underwear, tie a red cape around his neck, and jump out the window of his office and fly off doing superhero deeds. Of course, that meant that George and Harold didn't get punished because the principal, they'd been sent to the principal's office, and now he goes off doing superhero deeds, so they get off scot-free. So it's a very intelligent thing for them to have done. Anyway, the point of this is that ADHD is a problem for all of us healthcare professionals. It's also now very commonly known. Everybody knows somebody with ADHD. I want to ask you the same thing I asked lay audiences, I ask lay audiences, how many of you know somebody with ADHD? And every hand in the room goes up. Everybody knows a child with ADHD or an adult with ADHD, so it's a very common problem. Oh, by the way, these books are interesting. Who saw the puns in this? The guidance counselor's name is miscorrected. The school psychologist's name is Miss Labeler. So these are all the names. You've been in the field as long as I have, or as long as Danny has, if you would admit it. Then you know all these names are the names that have been used over the last 40 years to refer to the same group of children, and that's kids with ADHD. These are the three core symptoms. They haven't changed. These names have changed. Three core symptoms have been the same for 40 years. I'll skip over the definition. DSM-5 is basically the same as DSM-4, except that you can have onset up to the age of 12 instead of 7, I think it was before. You have to have impairment across settings and so forth. So what I wanted to mention from this is that these are the DSM symptoms of ADHD. For a long time, our group has been emphasizing that DSM symptoms are the least important thing that a parent or a teacher or a child or a therapist needs to know about ADHD. The most important thing is impairment. The problems in daily life functioning that kids have, which is a required part of diagnosis. And in my view, and there's good literature to support this, the DSM symptoms of ADHD are unimportant for almost everything. DSM symptoms don't predict outcome in children with ADHD. Impairment predicts outcome. DSM symptoms don't predict outcome. A child who's got just 5 symptoms of inattention or 5 symptoms of hyperactivity and impulsivity is going to have problems even though he doesn't have the diagnosis because he's 1 symptom short. So it's the problems in daily life functioning is what we need to think about as the clinicians that work with ADHD children and the things we need to track in treatment because that's what we want to change. It's the problems in daily life functioning. These are the problems that ADHD kids show, as most of you know, I'm sure. How many of you have worked with kids with ADHD as professionals, so I can see? Oh, good. So you all know this then. Parents, peers, academic achievement, behavioral functioning at school. And I'll do this very quickly since most of you know a lot. There's 40 years of research, or 50 years of research in child psychopathology in the broad field, showing that these are the key domains that predict outcome in children. And arguably the 3 domains that mediate outcome. So if you want to make a child's outcome better as he moves into adolescence and adulthood, you need to change his peer relationships to improve those. You need to change the way his parents parent and the parent-child relationships. And you need to change his academic achievement, behavioral adjustment at school. Those are the big domains that drive outcomes, not only of ADHD kids, but of most childhood disorders, period. So we want to change those targets. We want to target those in treatment, we want to monitor those in treatment, and we want to see if we can change them over time. So our goal is not to eliminate the DSM symptoms of ADHD. If the people who believe that it's a biological disorder are correct, then we can't eliminate things that are thought to be direct representations of what's going on in the central nervous system. But you can impact the problems in daily life functioning that those are thought to underlie. So daily life functioning is the goal, and daily life functioning has always been the goal of people from a psychological approach. So you use a behavioral approach and applied behavior analytic approach when you're working with kids, and those have always focused on problems in daily life functioning. Why is it important to treat ADHD in childhood? Because of the outcome if you don't treat, among other things. You want to help the child and help his family, but also the long-term outcome is not good. I think you can divide these outcome studies into about 3 groups. About a third of the kids have tolerable outcomes, about a third of the kids continue to have the same problems as adolescents and young adults, the same kinds of problems that we had as children, and about a third have really difficult outcomes. So our goal is not only to improve childhood functioning, but to lessen the likelihood that people will fall into the bottom 2 groups and maximize the likelihood they'll fall into the top group. We also, in addition to helping the individuals, we want to help society. It turns out that ADHD has a big cost to society. It's a big public health problem, even though people never think of it as a public health problem. Even in pediatrics, we think of asthma, for example, as the biggest health problem for children, for example. Diabetes as the biggest health problem for children, or obesity is the biggest health problem. ADHD is a really big problem. It's a big chunk of kids, and they cost a lot for society. Jess Robb and Mike Foster and I did you can't see the citation. In 2007, we did a review for the American Academy of Pediatrics looking at the cost of ADHD. We reviewed the review papers and the extant data and came up with this estimate of the annual cost of ADHD in the US. Now, this was based on a 5% prevalence rate, which as recent as 10 years ago is the number that people were using in the 2000 US Census, and it's in 2,000 US dollars, okay, in the year 2000. So these are big numbers, 36 to 50 billion, because there's no data for impact on the family, there's no data for vocational outcomes. That is, how does the young adult do with their ADHD and they are trying to become independent? How does that fit with other public health problems? Everybody knows major depression is a big public health problem. Everybody knows stroke is a big public health problem. Alzheimer's. Well, the cost of ADHD in children and adulthood is about the same as the cost of Alzheimer's to society. So it's a big problem, and we need to take it as seriously as we take curing Alzheimer's. Figuring out what to do about ADHD is as important to society, not to mention the individuals, as Alzheimer's. So what do we know about treating ADHD and trying to make the kids better? What's effective evidence-based treatment? I always start this with a list of treatments that are not evidence-based for ADHD. These are treatments that have no scientific support for ADHD, but they are some of the most commonly used treatments in the community, and have been for many, many years. So notice on here there's biofeedback, neural therapy, attention, neurofeedback, training, and so forth, number 5. About every decade that rears its ugly head. So for, back in the 70s, people started looking at this. Tried different things, nothing worked, it died away for a while, then a decade later, I think a new generation of graduate students looking for dissertations came along, and so people started doing it again. And it's happened a lot lately, but there's no good evidence for that. You may have read a couple of papers on CogMed, for example, but if you have, you should read the review papers that review all the literature, and they show there's nothing to that. So these are treatments that don't work, even though they're highly, highly commonly used for kids. Pet therapy came when I was watching the Today Show one day. And they had a person on saying if you buy a pet for all your kids with ADHD, you'll help the kids and cure ADHD. Hippotherapy, I've seen a lot recently. That's horse therapy, by the way. I don't know what, I guess hippo must be Latin or Greek for horse. Anyway, and then duct tape Latin is because a teacher maybe 7 or 8 years ago in Missouri got arrested for duct taping his ADHD child to his desk and duct taping his mouth closed. I can't believe a teacher would do that, would think of that, but I also can't believe that people would think that there would be no negative consequences, that the child would go home and not say anything to his parents about the fact that he'd been taped to his desk for the day. Anyway, these are the only things that work. And every review paper on treatment for ADHD says the same thing, and all the guidelines of treatment. Behavioral intervention, stimulant medication, and then you can put the two of them together. And there's lots of studies on both. Most of my colleagues who are psychiatrists list CNS stimulant medication first, and then list behavioral interventions second. But there's good evidence for all of those things for short-term effects. So the short term is underlined there. Despite the fact that 2 main treatments are evidence-based, in the US, the one that is used as first-line treatment almost always, and the one that is the treatment that every kid gets, or 90% of kids get, is medication. Even though there's solid evidence for both of these, and the research reviews say both of these work, and the guidelines say both work. So one of the things we've been doing for a number of years is looking at sequencing. So if both these things work, does it make a difference the order in which we try it, and dosing? If both these things work, what if we use a high dose of one of the treatments? What does that do to the need for the other treatment? Guidelines on Treatments and Sequencing, the Task Force of American Psychological Association in 2007 of psychologists said you should use psychosocial treatment first. And the reason they said that is there was good evidence for it, and the side effect profile is lower for psychosocial treatments than it is for medication treatment. The ACAP guidelines say medication first. It's in 2007. For those of you're all pediatricians in here, so ACAP is child psychiatry, the American Association for Child and Adolescent Psychiatry. And the ACAP guidelines say medication first. In fact, the ACAP guidelines, you have to get to recommendation 6 before you get to psychosocial treatment. It's start with one stimulant, switch to a different stimulant. If it doesn't work, increase the dose. Try a non-stimulant if those didn't work, and then add another medication. And after you try all those, then it says, and then if none of that works, you can try parent treating. So there are big differences based on professional orientation. The Japanese pediatric guidelines say behavioral treatments first. The British guidelines say behavioral first in mild to moderate cases and in young kids. CHAD says everybody should get both. And the American Academy of Pediatrics in 2011, the last set of recommendations said this: for elementary age children, the primary care physician can do psychosocial treatment or medication or, preferably both. For children under 6, behavior therapy should be first-line treatment. The CDC put out some publicity and a campaign this summer saying that people weren't paying attention to this, and they needed to pay attention to it. And young kids really shouldn't be getting medication as the first-line treatment at all. And for adolescents, the AAP said medication should be first and behavior therapy should be an ancillary treatment. I found that to be an astonishingly uninformed recommendation. I don't know how many of you have followed your patients as they move through childhood and adolescence and tried to keep them on medication, but you can't do it. And you may not know that because you still see some of your patients coming back. The successful ones keep coming back to you, the ones whose parents can convince them to stay on medication. But the vast majority of ADHD kids who were treated with medication move into adolescence, by the time they're 16, have quit taking medication. And you can't get them back on medication. You can't even get them to participate in a study designed to find out if you can get them back on medication. So medication is not, and everybody who's a researcher in ADHD knows this. Nobody wants to do studies with adolescents because they know they're not going to work because they can't get the kids to take the medication. So it's useful for kids, and it's not useful for adolescents for the most part. This slide just says stuff you probably already know. In the US now, we spend more money on psychotropics, specifically stimulant medication, than we do in antibiotics in the field of child treatments. More money on stimulant medications than on antibiotics. I like this. That's the doctor looking like a NASCAR driver. So those are all drug company patches. And as you all know, every clipboard in every pediatric office in America was paid for by either Shire or Johnson & Johnson. There's lots of advertising for pharmaceutical companies, and there's no advertising for psychosocial treatments because there is no giant corporation that sells psychosocial treatments. This just shows the prevalence of the use of stimulants over a 10-year period, the increase in the use of stimulants over a 10-year period. This shows that it continued over the next 5 years after that, and there have been a couple of studies showing that it's continued to go up since 2008. So big increases in stimulants. I think the main reason for this, I always had media people ask me why this is the case. Is it because there's something in the water that's been introduced recently is making more kids have ADHD? Is it because of changes in schools, changes in parenting? I think a careful examination says this is probably the result of two things. One was the 1991 ruling of the U.S. Department of Education that ADHD kids are eligible for special services in schools, and the memo that was sent to all state officers of education saying ADHD kids can be served in schools. They can have 504 plans, they can go to special ed. You need to alert all of your school districts to this, and they need to be paying attention to who's got ADHD. That caused a big bump in ADHD recognition and identification. And then in 1999, 2000, when Concerta and long-acting Adderall were approved, we got another big bump. And that happened at exactly the same time as the MTA study was published, which was a big NIMH consensus trial. Actually, in the year before that, there was an NIMH consensus meeting, which produced a document. And all of those, the MTA study and the consensus document said medication is the way we should be moving first to treat kids with ADHD. And then we got two big drug companies that produced long-acting versions of medication, and they hired tens of thousands of reps. And so we got lots more information to doctors and more kids got identified. And I think that a careful analysis, if anybody wants to spend the time to do it, would show those are the two big things that happen to increase the prevalence rate for ADHD. So it shouldn't be the case that all of this medication is being used. When we know that behavioral treatment works, how come more kids don't get behavioral treatments? Now, my view has always been that behavioral intervention should be first line and medication should be an adjunct. In fact, when I came into the field, that's what everything said. Medication should be an adjunctive treatment to behavioral treatment. That's kind of slid by the wayside. Why is it important to include? Oh, and also in behavioral treatment, we're talking about teaching parents. We're talking about skills training. So for behavioral treatment, you teach parents better parenting skills. You teach teachers better classroom management skills. And you teach the children themselves better peer relationship skills. So it's skills training for parents, teachers, and kids if you're doing behavioral treatment. Not individual psychotherapy, it's skills training. And why is it important? Parents of ADHD kids have a lot of problem with stress resulting from interacting with kids. They have high rates of psychopathology themselves, and no one ever taught them to be a parent. How many people here have kids? Raise your hand if you have kids. Please, hi. Raise your hand, hi, okay. Now leave your hand up, what is that? Leave your hand up if before you had your child and had to raise them, you took a course in how to raise children. How many of you got a license in how to raise children? Raising children, which is the most important thing we do as a society, as a species, is the only thing in America you can do with no license and no training. Everything else we do, we have to have license and training, and that's terrible. So we want to teach parents of ADHD kids who have a much harder job than the rest of us how to best manage their children's behavior. We don't teach anybody that. We really need to teach that to parents of ADHD kids. ADHD kids have terrible problems in school throughout their entire range. I'm not going to have time to go into that, but you all know that school is a big issue. I know Jeff has published recently in homework, for example. There are lots of aspects of school that are really problematic for kids with ADHD. There needs to be big-time intervention there. I actually did a back-of-the-envelope assessment for our group to decide whether kids in the Miami-Dade School District are getting served adequately. Kids who have ADHD. They have no records on who has ADHD because it's not a diagnostic category, not a category that they have to track for special ed. But you can come up with, by looking at the prevalence rate and the number of kids who have 504 plans, and the number of kids who have IEPs, and the national studies of the prevalence of ADHD within those groups, you can get a pretty good estimate. And the Miami-Dade schools arguably have 39,000 kids with ADHD, and about 7,000 of them have a 504 plan or an IEP. That means 32,000 of the 39,000 are getting no treatment from the school. Okay, and the last one is they have severely disturbed peer relationships, and peer relationships, of all those things we talked about, parenting, school, and peer relationships. Peer relationships have long been shown to be the most important driver of long-term outcomes. If you can improve those and teach a child with ADHD how to get along better with other kids, that may be more important than anything else you can do to help them in the long run. This is just a picture of a mom who had 5 ADHD kids and what it drove her to do. Unless you think I'm politically incorrect, that's a broom with a fork tied in the end of it, not a shotgun that she's using to hold up the pharmacy. Okay, I'm going to skip parent training, skip school intervention, skip peer relationships, because I want to get into the medication stuff. Beneficial effects of behavioral treatments are just like are what you expect from all good psychotherapy. Parents get better parenting, teachers get better classroom management, kids show better functioning at home and at school, and better functioning with children, with other kids. Okay, stimulant medication. You all know how stimulants work. If I was kidnapped by a terrorist or a criminal who said to me, we're going to keep you until the guy has an ADHD kid, so he kidnapped me because he saw my name in the paper saying I could do good things for treatment for kids with ADHD. So I've kidnapped you and I'm going to keep you in my house locked up until you cure my child with ADHD. I would ask if he has a pediatrician for his child. And I would say, well, let's go talk to him and see if we can get some medication for the kid, because I know if I do that, 20 minutes after the child takes the pill, he'll let me go. And I want to make that happen fast. Of course, I don't want to stay around for 12 hours or 13 hours because the effects will be worn off. So the effects of medication are short-term, and they're big effects. But there's several limitations to medication. These are all the short-term effects that you know, and they are big effects, there's no denying that. Anybody who's seen a child with ADHD, medicated and unmedicated, knows these effects. And by the way, of my papers, probably a third of those 400 papers are medication studies. I get into medication studies very early because everybody was medicated. So every child that got sent to me for behavioral treatment was already taking medication. So I had to figure out what medication did, what I could do to work with it, and so forth. So here are limitations of medication, and the limitations are important to know. The single biggest limitation of medication, I think, is the one highlighted in yellow there. Medication has no long-term benefits, and that's undeniable. That's absolutely clear from research that goes back again 40 years. 40 years ago, people published attempts to find out whether medication had long-term benefits for kids with ADHD, and it didn't 40 years ago. All the studies since then, it didn't. The MTA study is the latest gigantic study. The MTA published a splashy paper in 1999 saying medication was the best treatment for kids with ADHD. At the time that was published, I was part of the group that published it, we already knew that 50% of that benefit was gone 2 years later because we'd already done the 2-year follow-up. And 6 months later, when we published the 2-year follow-up, we already knew that the 3-year follow-up showed there's no benefit of medication, none. Only 2 years after we finished the study. And 2 years ago, we published the 10-year follow-up that shows that 10 years later, you can't find any evidence that medication has any benefit on the kids in that very large national study. So that's the single biggest problem. So if we know that ADHD kids have problems that extend throughout their life, they don't just miraculously, spontaneously recover at age 12, they have problems that go on throughout adolescence, throughout adulthood, and so forth, then our treatment needs to be something that has a lasting long-term benefit, and medication does not. If you disbelieve me about that, come up and argue with me afterwards. We can have a good discussion, but the data are really clear on that that's the case. All these other things are like a reduction in growth. It is true in the latest MTA studies, it's going to show that that it's probably actually what Jan Loney showed 40 years ago. About 2 inches loss in adult height if you medicate a child for most of their childhood and into their early adolescence. Is that bad? It depends on how the parents feel, how the child feels, what you want their outcomes to be. It does mean that child's going to earn, what does the economic data show? I think it's $500 per year per inch you make less in life with each loss of an inch of height. So tall people make more money throughout their life. Congratulations to everybody out there who's tall. What I don't know is if you wear boosters in your shoes, I don't know if that does the same thing. It might. Anyway, that's the big problem. Reduction in growth, and that's if you take medication at a pretty hefty dose for 10 years. Okay, if you take it at a lower dose, very low doses, the kinds I'll talk about later, there aren't any effects. So that's all dose dependent and how long you took it. And then there's been a lot of debate about long-term safety. We know almost nothing about long-term safety of stimulants, but it doesn't appear that it causes substance use, which is one of the major things that people worried about. There's still some people who say that it benefits substance use, and I think that's absurd. The group that says that simultaneously publishes other papers saying that they can't find evidence for it. So it doesn't help substance abuse, but it doesn't increase the risk for it either. So it's mainly, it doesn't have any effects in the long run. It doesn't help you in the long run. That's the major reason I think we should be doing other things. We should be adding behavioral treatments in the medication, because medication alone is insufficient. And among the things that medication has the least effects on are children's interaction with their parents in the evening when they're at home. Because even Concerta stops about 6 o'clock at night. So for the rest of the time of the night, there's no benefit for the child. I was just telling Jeff, we have a paper on parent training for homework that's just come out online, and it looked at medication. And to my astonishment, it said that Concerta had no benefit on kids doing their homework at night. Now, every doctor in the country will say, no, the reason we're using this is because it will help you, and it doesn't. I was really surprised at that. Parent training using Tom Powers' program for teaching parents how to set up homework routines does work, and the medication didn't, and the combination was no better than the parent training alone. If you want a copy of that, email me and I'll send you a online preprint of it. Okay, and these are just studies, medication studies that we've done and other people have done, demonstrating some of those limitations. But I want to skip over those. This is a big one, the MTA group. MTA group investigators recommended medication, but that's not what the parents in the study wanted to happen. They liked the behavioral treatment that they got better than the medication. And the last thing is, since the MTA study has been done, this is a BOE analysis. How many of you have had your methods course as residents, or so you know what a BOE analysis is, right?
Tell us.
It's back of the envelope. It's where Abraham Lincoln wrote his Gettysburg Address. So it's when you're sitting around thinking about things and you have an idea, and then you just grab an envelope or a scrap of paper and you start writing things down. I don't know how I had the epiphany, but once I thought, well, you know, we've probably, after we've done the first Concerta study, we're now giving kids way more medication than we did when I started in the field, when Danny started in the field, because they used to have short-acting methylphenidate, and kids only took medication for school hours. They didn't take it in the evening, they didn't take it at home. And if you look at what happened, what it was like before 2000, which is when the long-acting stimulants came out and the MTA was published. Before, the average kid took medication from 1 to 3 years, and they took 15 to 20 milligrams of methylphenidate equivalent during the day. And that meant over their lifetime, they took this much methylphenidate. And then when we switched to long-acting stimulants, Concerta, Adderall XR, you look at methylphenidate equivalents, the recommendations were medicate kids starting early, don't stop, medicate as long as you can get them to still take the medication, medicate 7 days a week, and use long-acting stimulants. And if you just do the math, you take, okay, what was the increase in medication? What's the increase in the number of days taken per year, the number of years that kids were taking medication? The current recommendations for treatment, for medication treatment, are that kids would take 14,000 milligrams a year times 12 years. If you medicate for 12 years for a child all the way through school, you get 175,000 milligrams of methylphenidate consumed versus 5,000 to 10,000. And every time I see Javier Castellanos, who's a big neuroscience scientist in the field of ADHD, I ask him, do we yet know whether this is safe? Is it safe to put that much methylphenidate into people's central nervous system? And he says, Bill, you ask me this every year. No, we don't know if it's safe. And if I say, would you let your child take that much methylphenidate? He said, well, no, of course not. Who would do that? Anyway, so we just need to think about that. Is that increased safe? Okay, so what do studies of comparative and combined treatments show? I'm going to skip the MTA. This is the best representation I know of the results of the MTA study. This is the parable of the blind man and the elephant. It depends on who you are and what you think, okay? But it influenced the field for quite a while. But questions the MTA didn't answer were questions about dosing, about how long you have to take treatments, about what dose the treatment should be for behavioral treatment, pharmacological treatment, and what the sequence should be. And those questions are the questions that face all of you as pediatricians or as psychologists every day. The parent says, what should I do in treatment? You have to decide, what treatment you're going to use, how intense it's going to be, and which one you're going to start with. So since the MTA came out, we've gotten a number of grants to look at questions that the MTA didn't answer, these questions. So I'll show you one slide from one treatment that's, we were about halfway through publishing it. That is, and then I'll show you the new one, the latest new one that we did. So this one looked at dosing of treatment. We looked at different doses of medication, because we've done a study and inadvertently used a very low dose of medication, and inadvertently found that low dose really had big effects, but nobody ever used that dose. So we went at dosing. We looked at dosing of medication, and how high do you really have to go to get a good effect with medication, and when do you stop getting incremental benefit with dosing? The same for behavioral treatment. There were no dosing studies, so nobody knew how intense your behavioral treatment needed to be to have benefit, and nobody knew if you combined different levels of dose, what that would do. Could you get away with a very low dose of medication and a very low dose of behavioral treatment? And the benefit of a low dose of behavioral treatment is cost. It doesn't cost as much if you're doing group parent training and if you're just doing 8 sessions as opposed to PCIT, for example, which would be individual with lots of sessions. So dosing questions were important. So in this study, we did this in an analog summer setting. So we took our summer treatment program, and that involves having kids, 12 to 15 kids in a group with counselors who work with them. It's a very intensive behavioral program. We measure everything that we do with the kids. So they're in the classroom part of the day, they're in recreational settings part of the day. That's what a typical day looks like. It looks like a summer camp, but there's a therapeutic intervention overlaid on the summer camp. You're all welcome to come visit. If you want to see what we do in the summer treatment program, we run it at Paul Bell Middle School, which is out at the intersection of Flagler and the Turnpike, right next to FIU. And we do that every summer from late June until mid-August. And we have a whole host of behavioral interventions that we do with that. So we knew we could use that setting. Since we're in control, we hired the counselors who work with the kids. We can tell them what to do. We can teach them, you do this during these weeks, you do this during these weeks. So we designed a study where we used 4 different doses of medication. We used the procedure we had developed years ago for using medication, which means with stimulants you can change the dose every day. And that's very useful for a variety of reasons. So each kid had different doses of stimulants, changing every day. And for 3 weeks out of a 9-week summer, they had our regular high-intensity BMOD program, parent training, intense parent training, intense point system with the kids during the day, rewards all day long, consequences, timeout all day long, parent rewards at home, and so forth. And then we had 3 weeks where we had no behavior modification. We told the staff they couldn't use any behavioral interventions. They just had to keep their 15 kids there and prevent them from hurting each other or running away. And that turned out that's not easy at all. The counselors in those summers thought that we were secretly doing a stress-induced drinking study. They would all go to bars at night because they had such awful days during the day. But it was a great study to do because, and to do a behavioral treatment study, nobody had ever done one where you had no behavioral treatment, because it's so endemic in the background of our society that the only way to know how big the effect of a behavioral treatment is to make sure you have a condition that's just like placebo, where nothing's going on. And then we had a medium in between the two, so a watered down behavioral treatment, a low dose of behavioral treatment, because we wanted to see how far could we get with a low dose of treatment. So the results, so high intensity BMOD, low intensity BMOD, no BMOD, and the medication crossed over with kids. So we could look at every condition, the cross between behavioral treatment and medication. And all the graphs look like this. This is classroom rule violations. We have the same graphs for negative behaviors when they're interacting with other kids, for amount of academic work completed in the classroom, everything about recreational work. All the graphs look just like this. So this is the effect of 0, 0.15, 0.3, and 0.6 milligrams per kilogram of methylphenidate, given 3 times a day. That's equivalent in today's terms roughly to 18, 36, and 72 milligrams of Concerta, just so you know, for the 3 different conditions. Okay, that's medication on no BMOD weeks. So with no behavior modification, in the classroom, the average kid had almost 60 rule violations in 30 minutes. It was very difficult for the teachers to teach when the kids had no behavior modification in place and no medication. And then this is the effect of the behavioral treatment, the low dose behavioral treatment and the high dose behavioral treatment. So this is the first big surprise for us, was this, that we could really water down the behavioral treatment quite a bit and still get a bang of an effect in the classroom setting. And we got the same thing in the recreational setting. The other thing this showed is that whopping effects of increasing the dose of medication with no behavioral treatment, but very few effects of increasing the dose if you're using either of the behavioral treatment conditions. In fact, if you're using high BMOD, you only got an incremental benefit at this lowest dose. You get anything from going up to the next dose to the next 4 times higher dose. It was almost as good with this. So this red line made us start thinking, well, maybe a very low dose of medication and a very low dose of behavioral treatment is the way to go. Because a low dose behavioral treatment is less expensive and easier to do, easier for everybody to implement. And the low dose of medication in this study, 0.15 milligrams per kilogram, had no side effect detected by a parent or nurse or our staff at all. No kid had a side effect at that dose of medication. All the side effects started at 0.3, and they got much higher, of course, at 0.6. So that study said to us, the combined treatment was really good for kids. Behavior modification was as good as medication. So the effect of the decrease in the blue line and the difference between this and this are about the same. So intensive BMOD is just as good as intensive medication, but the low dose is what we got interested in. And we thought, okay, if low dose is good of each of these treatments, which one should we start with? Because that's still the logical question. Should I have every kid walk out of his first visit with a parent training session and a prescription for medication, or should I delay one or the other? And that's where all of our studies went after that. I'll skip the next study and just go to the current one. So this is the one that we just published. This study is looked at low dose behavioral treatment. And low dose behavioral treatment meant group parent training and only 8 sessions of it. So very low intensity treatment. And setting up a daily report card between the teacher and the parents to reinforce the child at home for a good day at school. That was the entire extent of the intervention. 8 sessions of group parent training, daily report card. That's low dose behavior mod. Or kids got randomly assigned to start with a low dose medication. And that was the dose that we had shown in the previous 2 studies to be effective, 0.15 mg per dose, okay? So you start with those. And then at 8 weeks, we assessed everybody. We looked at how they were doing. If they weren't doing well on the measures that we had decided to use to evaluate response to treatment, then they got re-randomized. And the re-randomization was give them more. The choice was give them more medication or give them more behavioral treatment if they started in either condition. Okay? And the choice was randomized. So this design enables you to have multiple randomizations and mix and match treatments, but it's always randomized. It's a very nice design. I wanted to do this study in 1995, and my statistician at CMU said, you can't do it because nobody knows how to analyze it. And then about 2003, a group of statisticians at Michigan and Penn State developed the way to analyze these data. And this is called the SMART design, S-M-A-R-T. It's a wonderful treatment design. So what we have here is start with behavioral treatment at low dose, start with medication at low dose. Whenever a child needs more treatment, he gets it, and you flip a coin to see if what he gets is a higher dose of what he started with, or the other modality gets added in. That was the question. But it's very relevant to what a doctor has to do. Okay. So I'll show you the results. The results are very interesting. And the analysis is very complicated. If you want to read the paper, it's in Journal of Clinical Child and Adolescent Psychology last month. I'll send you a copy if you want a PDF. And my advice to you is skip the entire methods and results section, because the analysis is really, it took me a long time to understand exactly how we were supposed to do this. Our statistician was Susan Murphy, who's the person that developed the procedures. And it took me probably, I don't know, 8 different 1-hour-long meetings with her before I understood what it was. So don't worry about understanding it, but it's very good. The analyses are very tight. Here's the main findings. So this is look at the top one because the bottom one's the same. Our gold standard outcome in studies of ADHD is usually, if you can afford to do it, is usually direct observations of the child's behavior in the classroom. Direct observations of disruptive behavior in the classroom. Overall, the first analysis you do in these designs is always, what was the effect of the initial randomization? So you take everybody who was assigned to behavioral treatment first, and you look at how they're doing, regardless of what happened to them over time, regardless of whether they never had to be re-randomized or they got re-randomized to either of the other conditions. If kids started with medication, they were substantially worse than kids who started with behavioral treatment, all other things being equal in the study. Okay, and that's a whopping significant difference, actually, in the way the kids function. The same is true for out-of-class disciplinary events. The same is true for most of the parent rating measures, not as much for ADHD symptoms as for ODD and CD, but ODD and CD are the major things you want to actually have improved in the classroom. You may not be able to change the ADHD symptoms as much. But the results were pretty clear across a whole variety of measures that people that started with behavioral treatment first did better. This is a year-long study. It started the first day of school, ended the last day of school for a whole year for all these kids. Okay, the other thing that we showed was that what happened afterwards was affected by what you started with. So if you happen to be in one of the randomized conditions where you started with behavioral treatment and then you got re-randomized to medication, or you started with medication and got re-randomized to behavioral treatment. So both those groups ended up getting, for most of the year, multimodal treatment. They got the combination of the two. The only difference is half of them started with medication, half started with behavior modification. That turned out to be a whopping difference. Those two groups were hugely different. This is MB means medication first, then behavioral added in if they needed it. MM means medication first, medication added if necessary. BM is behavior mod first, medication added if necessary. And BB is behavioral first, behavioral added if necessary. So you can see that the two behavioral first conditions, not surprisingly since this is better, were both better than the two medication ones. What I want you to see is that these two protocols, this one and this one, the kids got the same treatment. The only difference was the sequence with which they got it. And you can see there's a whopping difference, and that is a whopping difference. That's accounting for much of the difference between the two groups at the beginning. You also see that, this was a big surprise to us, kids who got more medication. So that was kind of traditional medication treatment. They started with medication. If they needed more, the doctor increased the dose. We increased the dose all year whenever they needed medication. That group did worse than the group that just got behavior mod and then got some more behavior mod. And that was a big surprise to us. I did not expect that. The other thing that I've skipped and haven't shown you is that half of the kids in the medication first group were fine and never needed any re-randomization. That meant half the kids we treated with medication were perfectly fine on 18 milligrams of Concerta. They never needed anything else. So we didn't do traditional titration, where you start with 18, and then you go up every week for 4 or 5 weeks until you get side effects. We just stuck with a low dose unless they needed it. That was shocking to us. However, what this shows, the fact that, have I lost my battery? Oh, there we go. The fact that these two groups were not good means that if a child was not a responder to the first dose of Concerta, the likelihood that he was going to be a responder to an increase in dose was not good at all. And that was a big surprise to us. Now what that means to me is that if you're the doctor, however, the kids who got medication and behavior modification didn't do quite as badly as the other kids. So if you're a doctor, you cannot predict who's going to respond to Concerta. So if you choose to start with medication, you need to realize that half your kids are going to do really well on a low dose of Concerta. But once you've done that, if your only option is to give them more medication, they're going to do terribly. That was a surprise to us. And we're going to do more studies to see if we can figure out why that's the case in kids. Okay, so that's the bottom line, is that starting with behavioral treatment first had a bigger effect, way more beneficial effect than starting with medication first, even if you ended up getting multimodal treatment. And the people that got behavioral and then more behavioral added in are doing better, that's this group, better than the kids that got medication and had more medication added in. And then the final thing I want to make, since I know we're ending time, I want to show 2 slides. One is, why do we think it happened? Why was starting with behavioral treatment better than medication? This is looking at the attendance at parent training. So if you are assigned as a parent to start with parent training, that's the behavioral first, then your attendance and involvement on all the metrics that one typically looks at were all very good. If you started with medication and then needed more treatment and got re-randomized to now go get some parent training, your attendance at parent training sessions, your uptake of the treatment is terrible. And we didn't expect that at all, but it's a whopping effect. And it probably caused the difference between the 2 groups. So medication appeared to undermine the parent's willingness to get involved in the behavioral treatment if you started medication first. Okay. And then the last thing is that we did an excellent, worked with economists to do an excellent cost of illness or cost of treatment analysis with these data. And what we showed basically was that the starting with behavioral treatment first was far less expensive than starting with medication first. All the conditions that involve behavioral treatments were less expensive than the conditions that involve medication. The most expensive condition in the study was medication. And the reason for that is, how many of you, who knows how much 1 pill of Concerta cost at retail? Take a guess. $8. You knew. You're right. It costs just under $8 for 1 pill of Concerta. Back when I started in the field, people took generic methylphenidate. You know what that costs today? A day to take generic methylphenidate for a day is 30 cents. So if you give Concerta, which is long-acting, $8, a little less. You give short-acting methylphenidate twice a day, that's 30 cents. That's a whopping difference. That's every day. One of the authors of the study said, wow, that means that if we didn't give Concerta for a week, that's what we would have to pay a social worker to see a kid and do parent training for an hour. Or, another way to think of it, every 2 days, if we didn't give a Concerta pill, parents could have a phone call with a parenting consultant on the phone for 15 minutes to talk about their issues and titrate what they're going to do at home in terms of behavior management. So medication turns out to be very expensive these days. And the costs showed that every condition that had behavioral treatment was cheaper than the conditions that had medication, and that starting with behavioral treatment was less expensive than starting with medication. Now what are we doing in the field? The opposite. Everybody gets medication as their first line of treatment, and parents, good pediatricians are saying to the parent, I'm giving you a prescription, but you should go see my good friend Joe Blow, who does parent training, or my good friend Jason, who does parent training. So be sure you go to Jason's clinic and get parent training, but here's your prescription for medication. And what people need to know is if you do it in that sequence, that a lot of those parents will never show up for parent training. But you do it in the opposite sequence, then you can get the parent training in first. So I said I wouldn't go over. That's the main points of this. Starting with behavioral treatment is better outcomes for kids, and less expensive than medication. Thank you.